Hello, everybody. We have Dr. Asha Mahilmaran with us from Apollo Chennai. She's a senior interventional cardiologist working with highly complex cases. Today, she had a presentation on intravascular lithotripsy, calcium modification technique in coronary artery disease. Dr. Asha, can you please give us your input?
Thank you, Dr. Mabeka. Calcium is always the difficult part of handling coronary lesions. They make the procedure more complex, they can result in complications, they increase the fluoroscopy time, they increase the contrast load, and sometimes they result in suboptimal result, which can lead on to subsequent stent thrombosis, or they can result in restenosis later on if you do not prepare the bed well. Fortunately, we have more and more tools today than earlier days in handling the calcific lesions. Traditionally, we've been using only rotational atherectomy, and subsequently we have the cutting balloon, the angiosculpt balloon, the OPN high pressure balloon to tackle the calcium. And now we have the next generation of tool, the IVL, the intravascular lithotripsy balloon. How is it different from the rest of it? You inflate it only to 4 atmospheres and it acts on sonic waves which are converted into mechanical energy, and they produce cracks on circumferential calcium, and they result in a preparation of the lumen, after which you can use a non-compliant balloon further on and you can deliver the stent appropriately. The advantage of intravascular lithotripsy is that it does not produce any major procedural complications or result in death, like cardiac tamponade, perforation, have not been reported so far with intravascular lithotripsy balloon. The only complications which have been noted are type B dissections, which can easily be tackled by deploying the stent. The other is an IVL balloon rupture. And this rupture also predominantly has been shown that if you mix the contrast with some air bubbles when you prepare, then the chances of balloon rupture are more. So when you do the balloon preparation, it is very important that you're very careful that there is no air bubble when you prepare it within the balloon, so that the chances of rupture are low. So beyond this, there has not been reported any death on table or perforation or any major adverse slow flow with this therapy. And that is the advantage of using an IVL in complex lesions, in patients with unstable clinical scenario, hemodynamic instability, even in a primary PCI. You can use an IVL balloon safely, and the learning curve is extremely low because all interventional cardiologists know how to use a balloon, and this is similar to that, a little more bulky. But if you can deliver it with the help of a guide extension catheter, even this can be tackled in most scenarios.
Excellent input, ma'am. Thank you so much for your excellent in-depth analysis of IVL.